Thank you for joining this talk on the treatment of COVID-19 as part of the Harvard Medical School COVID-19 video series. My name is Arthur Kim. I'm an associate professor of medicine at Harvard Medical School and a member of the Division of Infectious Diseases at Massachusetts General Hospital. These are my disclosures. I will also note that I'm a member of the NIH treatment guidelines for COVID-19, and all treatment that I will discuss will be off-label with one exception, which is remdesivir for hospitalized patients. The first question we will tackle is, why is the timing of COVID-19 treatment so important? The answer to that question is based in the stages of COVID-19 and the fact that most patients will have variable outcomes. So it's been better established by studies that up to 20% of individuals may have virtually no symptoms while carrying and able to transmit COVID-19. The majority of patients have what we would call mild or moderate illness, which is a self-limited illness that through supportive care, patients will recover and return close to their baseline state of health. Unfortunately, for this pandemic, a good proportion of individuals move on to what we would call severe COVID-19. While their definitions may vary, one simple definition is to think about it as patients who require oxygen. And then for a subset of those individuals, they will go on to need for organ support, largely through the acute respiratory distress syndrome, or ARDS. And it is through that stage that patients will experience the morbidity and mortality. Understanding those phases means that our potential intervention should be based on the stage of COVID-19. So early on, I'm showing you a slide of what we would call the viral load or cycle threshold measured from nasopharyngeal or other types of swabs. And what you're seeing here is that the peak of the viral load and the time at which the patients are most likely to be transmitting to others is shown there. But then just 5 to 10 days later, the peak has declined and the patient has a much lower likelihood of transmitting. And also, they are developing antibodies that would help fight off the virus. And so antivirals would be targeted to this earlier stage of infection. The middle section describes what we have learned about the pathogenesis of COVID-19, particularly in the early stages. So to simplify things, one could look at it like there can be an early, robust type 1 interferon response that is part of the innate immune system that then produces an adaptive immune response consisting largely of T cells and antibodies. And this robust response abrogates the viral infection, and the patient suffers from mild disease for some days, but then recovers. However, in a subset of individuals, the immunity is delayed. And here we're seeing the type 1 interferons coming up later and continuing into the severe phase. While antibodies and T cells do arrive, the T cells can often be lower in magnitude. And so during this time, one might try to optimize the immunity, either by stabilizing some of these pathways to shift towards the early, more robust response, and or even giving passive immunity to replace what would otherwise be a delayed immunity. And finally, for the severe to critical patients, what we've learned is that there can be a dysregulated immune response, the ARDS within the lung, associated with cytokines and what is termed a cytokine release syndrome, and as well as endothelial damage or immunothrombosis leading to thrombin production. And so during this time, one will be trying to dampen the immunopathogenesis and perhaps consider anticoagulation. And so when one considers the treatments, one can also, by stage, look at various outcomes. And so when one examines papers in these fields, please look at what the outcome is. And so for pre or post-exposure prophylaxis, their goals are to either prevent infection in the first place in the case of pre-exposure, or to reduce onward transmission for post-exposure prophylaxis. And then once one has COVID-19 or mild to moderate disease, it would take a very large study to look at mortality, since the majority of individuals do recover on their own. And so the endpoints tend to be reduction of the progression of illness, largely measured by hospitalization or attended medical visits. For the treatment of severe or critical COVID-19, this corresponds to hospitals. And here one can reduce the mortality, since there is a higher mortality in hospitalized individuals. So that is a very important outcome. But one can also look at morbidity. And so at times you will look at the decrease in organ-free days or in other complications. And again, one can try to enhance the immunity early on or optimize it, use antivirals early on, but then later you will be dampening immunity. For post-recovery, there are people who continue to experience symptoms, what we term the post-acute sequelae of COVID-19. Here we really lack an understanding of the pathogenesis, and therefore treatments are really unknown at this time. So what do we know? I have to credit the recovery study performed in the UK through the National Health Service there, as this study has enrolled over 40,000 individuals as of today. And this trial has shown a lack of efficacy of a variety of different interventions for hospitalized patients. Shown on the right is a survival curve if one gives azithromycin, a very popular choice because it did show some in vitro efficacy, as well as has anti-inflammatory properties for viruses that have been hypothesized for decades. And nevertheless, you can see the survival curves completely overlap. And so you're not saving lives by giving azithromycin. This graph looks at convalescent plasma. And here again, you see the overlap. And convalescent plasma has been given hundreds of thousands of times in this country, and but not so much in a randomized fashion the way it was in this study. And so while there could be benefit to convalescent plasma if administered super early, remember, by the time patients are in the hospital, we're talking 8 to 10 to 14 days into illness, when most patients will have antibodies. And so replacement of the antibodies in convalescent plasma did not work. Rather, this trial informed us almost 1 year ago at this time of the efficacy of dexamethasone for patients who are on oxygen. And this is the mainstay and largely the standard of care for patients. It's given at this dosing, 6 milligrams daily for up to 10 days, but should be stopped if the patient is recovered and is ready for discharge. This trial has also confirmed, along with another trial, REMAP-CAP, the efficacy of tocilizumab with dexamethasone, and in recovery for patients with C-reactive proteins, a marker of progression above 75 milligrams per deciliter. So this is a key slide from the recovery trial performed in the UK that demonstrated the efficacy of dexamethasone. And while overall results did show a mortality benefit, if one divides it by the stage of illness, one sees these differences. So on the left-hand slide, panel, I should say, if the patient was not on oxygen, dexamethasone was not associated with a mortality benefit. In fact, there was a trend towards harm. The benefit was largely seen in patients on oxygen, and even to a greater extent for those who are mechanically ventilated or on ECMO. And so the main messages here are that just because the dexamethasone is good in one stage, it doesn't mean that it's good for all stages of COVID-19. And so one should not use dexamethasone for patients not on oxygen, and one can extrapolate that one should not use it as well for outpatients. This slide summarizes what we are deploying in the United States for treatment, and will be reviewed in the next 2 segments. But what it shows is that regardless of the intervention, that it really depends on the stage, whether there is benefit. And so the pathogenesis and natural history of COVID-19 reveals treatment strategies based on the stage of infection. If it's mild to moderate, viral replication is the major driving force. One should also note that most do recover from this stage. And so why interfere with the immune system? Dampening the immune system may have deleterious effects towards that recovery. And so antiviral approaches should be emphasized. Whereas for severe and critical disease, patients moving into ARDS, immune dysregulation is the main pathogenic force. So antibodies are already generated in the majority of hospitalized patients, and thus it has been difficult to demonstrate that convalescent plasma and/or monoclonal antibodies are successful in this stage. Therapies may help patients, therefore, if they are timed correctly to the sweet spot, so to speak. And a therapy useful in one stage of COVID-19 may be useless or even harmful in another stage. Evidence-based approaches suggest reliance on randomized clinical trials to guide our clinical decisions.